Good afternoon and welcome to today's presentation, Top 5 Denials, Improve the Appeals Process and Focus on Denial Prevention. I'm Athena Mandros and I'm the Market Intelligence Director here at Open Minds. Today's executive briefing is brought to you by Open Minds and sponsored by Echo Group. This afternoon, we are joined by Ashley Gore, Revenue Cycle Manager, and Stephanie Blakeney, Revenue Cycle Team Lead at the Echo Group. During our time together, we will discuss the top 5 reasons payers deny claims, how to navigate the appeals process, and how to use key performance indicators to identify denial trends to prevent future denials. You may have noticed that all attendees have been muted for today's presentation. We are recording today's event and muting the phone lines assures the highest quality of sound. However, we do encourage you to submit questions via the question box on the GoToWebinar panel at any time throughout the presentation. And at the end of the presentation, we will hold a brief question and answer session. And with that, I'll turn it over to Ashley and Stephanie.
Thank you, Athena. So I'm Ashley Gore. I'm the Revenue Cycle Manager here at the Echo Group.
And I'm Stephanie Blakeney. I'm the Revenue Cycle Team Lead.
And Echo is a behavioral health software and services company. We've been providing services to behavioral health organizations for over 38 years. A number of the organizations that utilize our software have opted to outsource billing responsibilities to our revenue cycle department so that they can focus mainly on providing services to their communities. Denials will generally vary depending on an organization's service and payer mix, as well as requirements and standards that vary depending on state. As mentioned, our agenda for today's presentation will be to touch on common denials, discuss industry standards and best practice for denial management, track performance using key performance indicators, and go over the appeals process. The most common denials that organizations report are coding errors, missing information, timely filing, non-covered charges, and duplicate or inclusive services. We'd like to dive a little bit into how this can occur and what you can do to be more proactive instead of reactive when it comes to denial management. Coding errors can occur for various reasons, but most commonly we see them in cases where an invalid diagnosis was reported. Whether it be that the code itself is not billable or not specific enough, or for example, if a medical diagnosis is reported on a behavioral health claim. You may also see coding errors in situations where the bill code and modifier combination is not valid either altogether or is not valid for the provider on the claim based on their specific license. Missing information on claims is another common denial reason. It occurs when the claim is missing certain data that's required to adjudicate the claim, such as the NPI, maybe required modifiers, patient demographics, such as their gender or date of birth, other payer information, or their ID number, things like that, or a procedure description for non-specific billing codes, among many other reasons, of course. Timely filing denials occur when the claim is submitted past the filing limitation guidelines set forth by the payer. Every payer is really different when it comes to this. There are timely filing limitations that vary from 60 days to a year for initial claims, and then they change for resubmissions or appeals as well. So it's really important to know what those are. Timely filing happens with the first time submissions, especially when rejections are not being reviewed. So if you're submitting your claims and not following up on your file submissions to make sure the files were accepted or that all the claims within that file were accepted, you may be at risk for timely filing because those claims aren't going to be on file. This also occurs when corrected claims are not submitted within the allowed filing limits, or when the secondary payer isn't billed within the time frame allowed by the date of the primary payer EOB. Non-covered charges typically occur when billing for services that are not covered under the terms of your contract with the payer. However, we also see this in situations where the service is not covered due to other reasons, such as the individual provider's credentials, or in some cases, even due to the age or gender of the client. Duplicate denials can often occur for other reasons. The claim could have been billed out multiple times as an initial claim. This occurs from resubmitting the claim without updating the claim frequency code to identify that it's a resubmission. You may not have referenced the claim number on your resubmission, and so the payer is going to identify it as a second or third initial claim, and they're going to kick them back as duplicates. It could be that the service was entered more than once into your EHR, and both ended up being billed out. We've also seen instances where a claim is billed, but Medicare also crossed over. So that additional claim would have been denied as a duplicate. In some cases, services that should have bundled together into one service may have billed individually, resulting in duplicate denials as well. Inclusive denials basically means that payment for one service was included in the payment of another service that took place on the same day. This typically happens when a modifier is not appended to the appropriate bill code to indicate that it was a separate service. As an example, 25 would be appended to an E&M code if another separate service was rendered on the same day. And if they're billed together or separately without that modifier, the payers typically will pay one of those services and then deny the other one, saying that payment for that primary procedure covers both. Many of these denials can be prevented by building staff awareness. Denials are not a billing department problem. They're an organization-wide problem, and everyone is responsible for helping to prevent the delay or loss in cash that denials cause. Implementing benchmarks based on your specific organization and holding all of your staff accountable to meeting those benchmarks is key to creating a cohesive environment where everyone is contributing to the financial success of the organization. We've had the opportunity to work with, in Revenue Cycle, to work with many different agencies that use our EHR, and that has allowed us to observe some very successful team dynamics. And I'd like to mention one organization in particular that ends each day with a team meeting. Those meetings include staff from each area, including administrative managers, clinical program managers, IT, and so forth. In those meetings, they, as a group, come together to discuss the day's outcomes. They go over challenges they experienced that day. They also provide feedback to one another for improvement, and they strategize as a group to come up with preventative actions. The cohesiveness of this particular group is evident in their financial health and their ability to successfully serve their community.
Some of the national benchmarks to take into account when determining goals specific to your organizations are denial rate, days in AR, and percent in AR. Your denial rate is determined by calculating the total denials received in a given month and dividing that total into your total billable charges created for the same month. A healthy denial rate for the behavioral health industry is between 5 and 10%, with of course below 5% being the healthiest. For days in AR, if you would like to know how this is calculated, please let us know at the end of the session and we can go over how to manually calculate your days in AR if your EHR does not provide metrics to that extent. A healthy days in AR varies depending on the service and payer mix for your organization. Typically, with outpatient services, days in AR should be between 30 to 45 days to be considered healthy. For inpatient services, days in AR should be between 45 to 55 days to be considered healthy. Again, these can fluctuate depending on your payer and service mix. If you bill infrequently for commercial payers and your payer mix is predominantly Medicaid or managed care, your days in AR could be 30 days or less. With percent in AR, you want to review the different buckets for your aged receivables, such as 0 to 30 days, 31 to 60 days, and so on. A healthy percent in AR over 60 days should be at 31% or less, with 7% or less in the 61 to 90 bucket and 24% or less in the 90 and over bucket. A majority of your overall AR should be in the 0 to 30 or 31 to 60 buckets, depending on billing frequency. Billing frequency depends on the services you provide. For example, residential may require monthly billing, which would of course result in higher days in AR. We also see days in AR fluctuate depending on the payer mix, since payer adjudication varies across the board. Maintaining a high-level overview of metrics will allow you to see where your organization ended the month, and if your goal was not reached, you can then review those areas at a more detailed level, as you can see here. Your denial management tool should break down the various denial reasons that were received for the time period you are reviewing. As you can see in this example, of the 8% denial rate for this particular month, we are able to identify the areas that need workflow review and perhaps improvement. The highlighted areas in this instance show eligibility and billing errors. You will also see there are some other reasons listed as well that contributed to the 8% denial rate. If your particular organization receives a high volume of denials for non-covered services, it might make sense to reevaluate your contracts and possibly renegotiate service coverage. If the services are not covered due to the provider's credentials, you may want to reconsider assigning the staff to clients with payers they are able to bill under, or ensure efforts are being made to credential the staff for that particular payer. The goal is to identify your organization's most common denials and how to improve business processes to prevent those denials. If we go back to the common denials previously discussed, everyone can contribute to preventing them in the future. Since coding errors are typically caused by diagnosis issues, it's important to provide education and materials to clinical staff on diagnoses that are appropriate for the services they are rendering, and possibly provide them with a tool that allows them to identify diagnoses that are not billable, such as an online tool or utilizing your EHR. If your organization is not seeing denials for the ones previously mentioned, and instead you're seeing denials related to eligibility or authorizations, which are typically verified or obtained prior to the client being seen, or since in behavioral health, we see a lot of same-day services, at a minimum, they should be verified or obtained prior to the charges being created and billed. If that's the case, here are a few questions you want to ask yourself. Where is the breakdown in the process? Are the front desk staff requesting copies of insurance cards when the client comes in? If so, is the data entry of the insurance information from the card accurate? A lot of times we'll see policy numbers or names misspelled or entered incorrectly. These can obviously cause errors when billed out if they're not caught in time. If eligibility is being run on a regular basis, you should be able to capture changes made to policies. However, if you aren't keeping up with the eligibility on a regular basis, you might want to consider doing that to prevent claims from going out to the wrong payer and denying. Are authorizations being tracked and renewed on time? There are many different tools that exist to help in this area. In fact, many EHRs have authorization tracking tools. In essence, you should determine your specific organization's common denials and work together as a team to implement new workflows and revise existing workflows to improve your metrics and overall financial health.
Before you send an appeal, you'll want to determine if that's actually the action that you need to take. An appeal should only be sent when you disagree with the decision of the payer. For reasons such as non-covered service, if you know that service is covered under your contract and you can provide that contract to support your claim against the payer. A corrected claim, on the other hand, would be sent when the reason the claim denied was actually valid. And in that case, you would need to update the data on the claim, for instance, such as diagnosis, modifier, maybe the client demographics, like the ID number, and then needing to resubmit it. In this case, you would use the claim number from the denial, change your claim frequency code so that the claim can be identified by the payer as a corrected claim and not an initial claim. Prior to putting time and effort into the appeals process, it's important to determine if it's cost effective. If you're spending several hours or days possibly working on $5 or $10 worth of reimbursement, it may not make sense from a cost perspective to pursue that appeal. You also want to be sure to identify all levels of appeal or escalation. You need to be familiar with who all of your contacts are at the payers and become relatively good friends with your provider reps. If you're experiencing an ongoing issue and you need to resubmit or appeal a mass amount of claims, they may be open to accepting a project from you. So it's really important that you know who your contacts are, and if there is a different contact for different situations or different issues, maybe there's a contact if there's a credentialing issue, maybe there's a contact if there's issues with the payer's claims editing software, and it's really important to know who your resources are at the payer so that the appeals process can be expedited so that it can go smoothly and is more cost effective, so that the time and resources you're personally putting into appealing those claims will come out in the outcome at the end when the appeal is paid. If there are different levels of appeal or escalation, be sure to follow up. Don't give up on the first attempt if that denies. Try to be persistent if a second level appeal might result in payment. Just be sure to always keep in mind to see if it's still cost effective to continue with the process. A lot of times we run into situations where the first level appeal denies even with the supporting documentation, and there's an escalation team, or there's second level appeal, third level appeal in different departments, and when that information is provided to them, sometimes they can go a little bit more into detail and review a little bit more in depth and overturn the decision.
It's really important to know your contracts. Payers have a timely filing limitation, not only for the initial claim submission, but also any follow-up redetermination requests, including corrected claims and appeals. Make sure you know your payer's guidelines and have your companion guides, fee schedules, and any other material provided by the payer readily accessible. These will be valuable resources when compiling your appeals. Some of the documentation that would need to be included in your appeals are progress notes, medical records, treatment plans, pretty much anything that can support medical necessity. You might also need coordination of benefits from the previous payer, or another form of proof of timely submission, such as historical documentation from your clearinghouse. In situations where your appeal is based on the payer's guidelines, you would want to attach a copy of the fee schedule, contract, or companion guide, possibly even a roster, illustrating your compliance with their documented requirements.
When writing your appeal letter, be sure to try and make it as unique, detailed, and informative as possible. Each client should have their own appeal letter, even if you're appealing for the same reason for multiple clients. Insurance appeals departments don't typically want to see, if they receive a group of appeals, they're not going to want to see the same letter stapled to the same documentation for multiple people. They want your claim to them to be unique and informative and really give them the information that they need to overturn their decision. The appeal letter should be addressed to the appropriate person or department and reference all of the information needed for that payer to locate the claim that they had originally denied. Try to stay away from templates as much as possible. Sending an appeal that basically says, please see the attached supporting documentation and reprocess accordingly isn't exactly going to motivate the payer to reconsider your claim. It's your job in submitting that appeal to build a compelling case and provide documented support that will leave the payer very little room and to disagree, and really give them no choice but to overturn their original decision. We like to use language from the payer's own guidelines and attach copies of those guidelines to the appeal. This makes it more challenging for the payer to dispute your claim. So a lot of times when we're submitting appeals, we don't use templates in our case. We write appeals as they come up, as the situations arise. We identify all the levels of appeal that can be made at those payers, and our first attempt always has all the information that's required in the appeal, of course. So the appeal letter, including all the information needed to identify the original claim. It has the reason that we're appealing, the decision of the original decision that we're now appealing, and why we think they should overturn their decision. Why should they pay that claim? And then everything that's attached to that appeal letter should support that, whether it be, as Stephanie mentioned, medical necessity if it's denied for not medically necessary, or if they deny it for not covered charge. Your goal would be to show them, this is the contract that I have with you, and this shows that this is a covered service. Or in cases where
you can also show as well if they've previously paid the service before, that there's kind of a statute in place that they've now paid it before, so they should continue to pay it. One of the things to also consider is that at times denials can occur, and again, being familiar with what's common for your agency or your organization will help you notice trends that might not be necessarily caused internally. In several of our agencies, we've noticed that the clearinghouse itself had an edit that caused things to go out incorrectly. They modified some of the files, or the payers themselves have software that modifies the files, causing them to reject or deny. Yeah. So the claims editing software at the payer, we've seen it happen quite often, actually, where the claims editing software at the payer will modify information in our 837 files, and those deny, and we have to go back and show them that wasn't actually in what we submitted, and those are corrections that they need to make on their end. And again, those are all cases that you would bring to your provider rep to reprocess those internally on their end. That's why it's good to have a good relationship and a good rapport with those reps, so that it can expedite the process for you. It does look like there's a good amount of questions, so we're going to go ahead and wrap up the slides and address as many questions as we can before the end of the session. We go into questions here. The first question we're going to take a look at is, let's see, how do you calculate days in AR?
Okay, so calculating days in AR, there's a few different ways to calculate days in AR. The way we personally do it is we total the charges that were created over the last 3 months, including the month that we're currently closing. And we'll divide that by the number of days in those months. We then take that result and divide it into the ending AR total for the month that we are closing. And that will give you a good indication of your days in AR, how long it takes from when the service was rendered to when the service is paid. Okay. Looks like there's another question.
Where can I find what the national benchmarks are?
Let's see. Benchmarks are usually reported by a number of associations. MGMA is a good one to use. MGMA is the Medical Group Management Association. If you're a member, that's great. If not, the benchmarks are still available to review. If you have professional coders on staff, AAPC is a great resource for finding out what the national benchmarks are. And you may even be a member of an association that has benchmarks they can provide to you. And of course, it's always a good idea to make sure that those benchmarks are specific to the services that you provide, so that you're setting the goals for your organization, your staff.
Hi, Stephanie and Ashley. It sounds like we have a couple additional questions here.
Okay.
Can you talk about some of the top coding errors you see that are specific to behavioral health?
Top coding errors. So with regards to diagnosis codes, one of the more common coding errors that we notice would be where either would be like a medical diagnosis or a diagnosis that's not valid for behavioral health services being billed on that claim. We also see instances with coding errors for billing codes where, say, for individual therapy, the different level of care or the durations. For instance, if you're 90832, 90834, 90837, if the wrong level of that service is billed out, that's a coding error that that we see quite frequently as well. Modifier, coding with a modifier is probably the most frequent one that we do see, where the wrong modifier was used based on the license of the clinician that rendered the service. That's probably the most common one there, outside of the diagnosis
not being
specific enough or not being specific to behavioral health.
Great. And do you have some recommendations for how often to check eligibility? Our attendee says, we have a system, but it seems like we have to check eligibility daily as managed Medicaid can change so much.
Yeah, I would say probably a lot of other organizations run into the same situation, and it just really depends on your payer mix and your service mix. We run eligibility for a number of agencies, and we run them at different times. So for some of them, yes, we do run them daily, and it does take full-time employees to do that, where you're spending the entire day, depending on the size of your agency, verifying eligibility for the services that are going to take place the next business day. In other cases, we're able to check it weekly, and in some cases even monthly. We do have some organizations where the state that they are located only updates their Medicaid system once a month, so it wouldn't make sense to verify it any more frequently than that, because there wouldn't be any updates to their eligibility in between that. We do typically use a 270, 271 to check eligibility. And so that kind of expedites things for us, where we're able to run the report and send it to the payer, or actually in some cases to the clearinghouse, and the clearinghouse will respond relatively quickly, or the payer usually takes a day. And that information can then be, used to determine eligibility for the next day or the next week. We just try to make sure that it's run before the patient is seen, or at least before the charges are actually billed out. Once the charges are billed out and it denies for eligibility, then it's a lot harder to turn that around as opposed to if you're able to check it beforehand, before the client comes in or at the time the client comes in even.
Sure, that makes sense.
When the client does come in, though, that's kind of why we mentioned making sure that the front desk is aware that they need to be asking for any updates or any new insurance cards. If, for instance, the client comes in and they give the staff a new insurance card, then the staff could then pass it along and enter the information in so that ideally, if one payer ended, we can then bill the new updated payer as quickly as possible.
All right, so here's a good question. We cover a lot of payers. How do I figure out who our reps are for each one?
How do we find out who our reps are for each one?
Yep, for each of your payers.
Yep.
Well, a lot of times we find the provider reps right in the right online for that payer. Sometimes they're right in the companion guides or the phone numbers for providers, your provider services. Online, though, is most often where we find it. It'll show for your region. If it's a widely used payer across the country, for your region, who the provider rep is. If it's a provider rep that's specific to your state or county, those are, I would say, pretty commonly known if it's for your state. But you can always contact the payer and ask for who the provider rep would be to handle your agency, your organization.
And do you have a suggested way for managing that information? Should it be in a certain system, or is there a way that you guys prefer to handle that?
Who your reps are?
Yep.
So in our EHR, we're able to put all of our contacts right in the payer. So for each of our payers, we're able to put the reps, what their titles are, their contact information, emails, things like that. And that way, if there's someone that's your backup, or there's other employees that are working on those accounts, they're able to have the same information and share the same information, and it's not stored in someone's head or in someone's email or on their desktop. If it's not something that you can have in your EHR, then at least having some sort of a common area or a shared drive of some sort that multiple people can access, and having it maybe on a spreadsheet of who the provider reps are and for what different areas. There could be more than one provider rep, or you may want to know who the boss is for that provider rep, or the boss's boss for the provider rep, just in case you need to, expedite things a little bit more. So it's always important to have all of that information and make sure everyone that needs it has access to it.
All right, so what do you recommend when you have denial letters or appeal letters for 300 to 1,000 claims?
Those would be more of a mass resubmission, where you would be talking to the provider rep about either sending that as an encrypted file electronically, rebilling it completely electronically.
It depends, I guess, on so if it's 300 to 1,000 of the same reason that you're appealing, then yes, Stephanie's right. I would be contacting someone. I certainly wouldn't be writing up 1,000 appeal letters. I would probably be contacting the provider rep and seeing if I could initiate a project with them, explaining the situation and finding out what's the best way to send that to them. Again, to mimic Stephanie, it's in an electronic file that we can reference the timestamp of when that file was submitted, or can we send a spreadsheet or something along those lines listing out the claims? I think it doesn't happen very often, but it's happened once or twice where we've had to drop everything to paper and send it that way, and tracked to the provider rep. But I would say more often than not, they'd rather it comes in some sort of electronic format to them. But if you have 1,000 claims with different reasons, Yeah, I mean, it's again just looking at what's cost effective, I guess. Looking at, overall, how much are those claims worth? Is it, using a template isn't going to be very effective, especially if it's just one or two sentences. However, if it's the same reason, your best bet would be to contact someone and go about it that way.
How do you track the status of denials or appeals? Do you use paper or do you put them in your EHR?
We put them in the EHR, but I mean, every organization is going to do it differently. When we enter denials into the system, and then we're able to use the system to
generate a report, and then we can track it as that goes. If, for instance, we mailed an appeal letter, then we might send it certified mail so that we would have a way of actually tracking that they received it, and B, as follow-up, we could say, on such and such a date, we know that you received it. This is the certified tracking number, and we keep all of those in our records so that when we're following up on the status of those appeals, whether it be by calling the appeals departments or our provider rep, we'd be able to reference that documentation. If you faxed over documentation to them, holding on to the fax confirmation, pretty much any way you can prove that they received it is something you want to keep for your record so that anyone else on your team can access that and share that and communicate it with their provider reps or whoever's handling the reprocessing of those claims.
Yeah, and for tracking appeals, if you have some sort of a tickler system, whether it be in the EHR or another tool that you're using to follow up on appeals that are sent, for denials, using your EHR if possible to run reports on what your denials are, and what your denial rate is, your most common denials, and how to improve those so that you're minimizing the amount of denials that are coming in. But again, following up with them frequently. When we work denials, we follow up on them. If it's going to take 2 weeks or 30 days for that denial to be reconsidered when we resubmit it, or the appeal is going to take 45 to 60 days, that's reminders that need to be set to go back and then follow up on that if there's not some sort of a like Stephanie said, if there's not something coming back to you saying this was received and we have this and it's in process.
What do you do when you feel like your provider reps aren't being very helpful? Who do you go to? Do you go above their head?
Their boss. And if their boss isn't helpful, then we go up the chain, just as you would anywhere else, really, where someone's supposed to be providing service to you, and helping you provide services to your community.
It's important not to be intimidated. It's your responsibility as the provider to make sure that your staff is then being reimbursed for the services that they rendered. Those folks needed the assistance. You were there to provide the assistance, and it's just what's responsible.
A lot of times in behavioral health, you're looking at a lot of nonprofit organizations, and I think something that I try to stress to the payers as often as I can is that these are nonprofit organizations, and not paying these claims is really detrimental to their cash flow and their ability to continue providing services to their community. And these are services that are very needed. So if the provider rep themselves isn't helpful, I typically go to the next person above them. I ask who they report to. And if that person isn't helpful, I've gone up to the vice president or higher if I can. And that tends to generally get attention. So I haven't really had any issues past that. I haven't had an issue with no one at all responding to me, although I'm sure that does happen. But being aggressive, professionally aggressive, but aggressive is important because they will, their goal is to not pay you. So So just making sure that you're being persistent and you're following up and not letting them, brush you off or, brush you under the rug. You want your claims paid, and you want to know who you can speak to make sure that happens.
Right, that makes sense. What is your benchmark practice about appealing a denial due to a DOFR issue between the health plan and the IPA?
I didn't really hear. I'm sorry, Athena, can you repeat that?
Would you like me to read that again? It's a little in the weeds. What is your benchmark practice about appealing a denial due to a DOFR issue between the health plan and the IPA?
The coordination of benefits, is what it says. Yeah, if it's possible, I think we're having trouble hearing, understanding that question with the acronyms. I think it's not coming across the phone very well.
Okay, that's okay. Why don't we move on to the next one? I think we have one more question to finish up. So sometimes different organizations require different codes. For example, the primary requires T codes, but the secondary doesn't use T codes. How do you go about submitting that type of claim? Can you just submit it with the T codes to the secondary?
No.
P codes?
T codes, sorry, like T as in T-shirt.
So is it a HCPCS code that has like a T code? Okay. That happens quite often. Where you're billing one code to one payer and then that code is different for the next payer. That's set up in our EHR personally to make sure that for payer one, it's going out with, if, for instance, the CPT code, because that's what that service corresponds to. And then when it waterfalls after payment or some, denial, whatever the case may be at that primary payer, it's then transferring or waterfalling to the next payer with the appropriate code
or code
that corresponds to for that payer in that contract. So that's something that's automated in a lot of EHRs. So it's not really something when we process payments for the primary payer and it waterfalls, we just make sure that the code that's then generating is the code and modifier combination corresponding. It meets the requirements of that specific service to make sure that it's a valid code for what was actually rendered.
All right, so it sounds like having the right EHR can be really important there.
Yeah, definitely.
All right, so what happens when your payer doesn't tell you they denied the claim?
So if they didn't tell you that you denied the claim, that would be where your AR follow-up comes into play. So outside of working your denials, it's really important to make sure you have a workflow in place to work your AR, because AR is going to capture what you didn't receive in correspondence as a denial, or in cases where, for whatever reason, it's showing as not on file. Maybe it was a rejection that you missed, or who knows, maybe you sent it on paper and it got lost in the mail, because that seems to happen. And whatever the case may be, it just may not be on file, or the denial didn't get sent to you and it is denied. You need to, it's as an organization, that's one of the workflows that you should be implementing, is on top of denial work, is working your AR on a regular basis. It depends on your service mix, your payer mix, but we tend to work at every, we pull a new AR for all open aged receivables by client detail every month or month and a half, something like that, so that it's continually followed up on, and those claims aren't missed and end up timely.
one of the things that we've seen before is that, for instance, some payers will, if you're out of network, will send deductible information to the client, but they won't send it to the agency or the organization. So again, if you're tracking your AR and tracking your denials, if you didn't receive the denial then or the deductible amount, you would then call or contact your payer when you see it on your AR and it's still outstanding, and be able to say, I know that we billed this out on this date. Can you give me any information as to whether or not you received it? Typically, they'll just say, yes, we received it. If it was a situation where they applied it to deductible, they're usually pretty willing to explain what was applied to the deductible so you can enter that documentation in, and usually they'll fax it to you if you request it. But yeah, it's just making sure you're following through with the AR and catching those services that you may not have received documentation for a denial on or a rejection on, and making sure that those get resolved and paid.
Great. So to finish up, we have a little bit of clarification on our acronym question. What do you do when your claim keeps getting denied because everyone claims they're not responsible for it?
Oh, I see. So it was coordination benefits. Okay.
Yeah.
Well, I guess that happens for different reasons. If what we have what you have from the patient or from the client is that they have, payer A and payer B, and neither of them is willing to claim responsibility, it's really not up to you as an organization to figure out who their payers are. If payer A is saying, well, it's payer B, and payer B is saying it's payer A, typically what we have to do is have the member get involved and work that out with their payers so that they can straighten out in their system what the coordination of benefits is supposed to be. Because really you can only do as much as you can with the information that you have on hand. It's helpful if it's showing online or something along those lines. If it's a state-funded insurance that they do have it and that they are the primary, you can provide that documentation to them in an appeal or something along those lines. But really, it's the member's responsibility to make sure that the payers have the appropriate information on file with the payers that they have. And
sometimes it's just a matter of having the member contact their case manager in some situations and make sure that the proper documentation is provided to the payer, stating what the priorities are as far as their benefits are concerned, so that that can be better managed.
Yeah, Medicare may show that they're secondary, and the secondary may show that Medicare is primary, and that's really that can be difficult for you to have to prove. So if you can prove it, that's great. But if not, definitely putting that on the member is the route to go.
Well, thank you, Ashley and Stephanie, for answering all those questions. It was trial by fire. So thank you, everyone, for joining us today. Just as a reminder, you'll receive a copy of the webinar via email in the next few days, and it will include a PDF download and a recording of the presentation so that you can listen and reference again. Thanks so much, Ashley and Stephanie. Have a great day.
Have a great day. Bye-bye.
Thanks.